Good afternoon. I'm glad that I'm following those four very different, very interesting presentations, because they've given me all the data that I need to reflect around. I suppose some of this will be a response to much of what's been said. I refrain from making any responses or comments after them. This will seem quite indirect in many ways. I'm not really going to talk a great deal about the concrete details of prison lethal exchange, harm reduction in prisons, but I'd like to think about some other issues, about why it is that quite such a large proportion of my community ends up inside prisons in the first place. And I'd like to start out with a quotation from Michel Foucault, and not what might be expected, his book Discipline and Punish, which looked at the role of punishment, but his book on abnormality, the abnormals. If you are not like everybody else, then you are abnormal. If you are abnormal, then you are sick. These three categories, not being like everybody else, not being normal, and being sick, are in fact very different, but have been reduced to the same thing. I think this is quite an interesting way of looking at some of the ways in which people who use, and specifically people who inject illicit drugs, have been looked at and are considered, and why it is that punishment is deemed so necessary for what it is that we do, for why our behaviour has been deemed to be something that needs to be criminalised, something for which we need to be punished. So what exactly is punishing people who inject drugs all about? What is really going on behind the really quite horrific lack of harm reduction services inside prisons, which we've seen very well described today? If we look at global drug policy, we see that it is driven by a moral compass that is so skewed, so revoltingly screwed, that it is believed in the retentionist countries, those countries that retain the death penalty, that people deserve to be hanged for using or for possessing very small amounts of certain substances, usually the drug of their choice, or for trafficking in the drug of their choice. It is one in which hundreds of thousands of people are thrown into compulsory drug detention centres in the name of something called treatment. It is one that ensures that criminalisation, stigma, marginalisation and discrimination are basic facts of the lives of people who inject drugs, of whom between 54 and 69% will at some point in their lives be incarcerated. And that's the UNAIDS figure, I didn't make it up. 54 and 69% of people who inject drugs will at some point in their lives be incarcerated, usually multiple times. It is, I think, a medical and legal paternalism of the most appalling sort that member states of the United Nations have felt the need to so protect people, so protect people's health and prevent them from using certain drugs that they want to use, that they deserve stigma, discrimination, the denial of access to health services, the abrogation and violation of their most basic human rights, incarceration, and in some cases the death penalty. And that people think that this stigma and discrimination is deserved was demonstrated very well in a report written by Australia's peak network of people who use drugs, AVIL, a report called Why Shouldn't I Discriminate Against Them All?, in which people, large numbers of people from the general public, were asked what their attitudes were towards people who inject drugs. And the overall attitude was, well, why wouldn't I discriminate against them? The overall response was, it is a good thing to do. They deserve it. And moreover, if we do this, we will discourage other people from behaving in a similar way. So these two very similar, very linked messages. And this kind of message has sunk more widely into discourse around public health, with the idea that there is a positive use of stigma in public health campaigns. And that debate has played out in the pages of the International Journal of Drug Policy. And it's been a very interesting debate. And it's principally been around smoking. That if you stigmatise or discriminate against people who smoke cigarettes, that you will discourage them from their habit, and you will discourage others from taking up the habit. But I think we need to think what stigma and discrimination really means in the lives of people, who use drugs. Now, let me turn a little bit to hepatitis C, and I'm going to come back to these themes. Recent developments in the hepatitis C treatment pipeline represent what is potentially one of the most significant breakthroughs in clinical medicine of recent times. The possibility of very simply, very quickly, and for very minimal cost, achieving what is tantamount to a cure of the vast majority of the approximately 10 million members of my community who are living with an entirely avoidable, very easily preventable, pernicious infection caused by a virus that very silently wreaks havoc with our livers, kidneys, and circulatory systems, ultimately leading to advanced cirrhosis, cancer, morbidity, and death. It is, I think, absurd, cruel, and almost beyond belief that the transmission and acquisition of a disease of this severity and scale can be very easily and eminently preventable with adequate provision of and easy access to a set of what are in fact cheap, very easy to manufacture, disposable plastic, metal and cotton products. Needles, syringes, cookers, filters and water. They're not complex technical objects. Yet they are not provided either to scale, and in most prisons not at all, as we've seen. It is, I think, almost inexplicable, certainly to those of us who've looked at global drug policy and have looked at the evidence, that we now have ever more effective medicines that can bring about successful treatment of this disease of hepatitis C, but yet barely 1 to 2% of people who inject drugs living with it receive treatment annually, whilst 80% express willingness to receive that treatment. And this is not even to go into the debate around pricing, which I think is quite irrelevant here. Public health and political efforts to increase clean syringe and needle availability have been met with ideological, social and political barriers that have been quite extraordinary, effectively thwarting the successful delivery of one of the most efficacious biomedical technologies for preventing infections directly caused by this lack. So, prison needle and syringe programs. Let's think about them a little bit. Now, all of this background, all of these views, all of these attitudes are perhaps moot in the face of the extraordinary stigma and discrimination, misunderstanding, willingness not to understand, and widespread contempt with which we are met, quite simply, on the basis of what drugs we choose to use and how we choose to use them. Choices for which we are subject to almost blanket global criminalisation, driving a very wide range of extraordinary human rights violations that much of the general public, as I've said, believe to be justified and to be well earned. And along with them, very serious health consequences on a global and systemic scale. And there are two major reasons given for not treating people who inject drugs for hepatitis C infection. Non-compliance or lack of adherence. Now, if you look at the petty rules employed in an opiate substitution therapy program or a needle and syringe program, You can bet we are very, very good at obeying very petty, very trivial rules. The other major reason given is we might go out and get reinfected, as if people who inject drugs willingly go out and get reinfected. You only get reinfected when you use somebody else's syringe, the syringe of somebody living with hepatitis C. Now, I was asked a while ago by a UNODC technical officer why it is that people who inject drugs don't like reusing syringes or needles. And I was quite astonished by this, but the woman simply didn't know. That's very simple. Well, actually, it hurts. People who inject drugs like their prevention technologies. We like to use them. It makes it easier and it prevents us getting hepatitis C and HIV. The reinfection argument does not work. The figures, the studies also show that rates of reinfection are extraordinarily low. Besides, arguments around reinfection would not be applied to any other viral infection. Chlamydia, for example. You might go and have sex again and get chlamydia. We're not going to treat you. It would not be applied. So there's obviously a great deal of stake in this very intense focus on patient non-compliance. And those who argue that entire classes of HIV or hepatitis C infected people lack what is thought of as the personal discipline to abstain from health-threatening activities, this fact of infection is turned into almost a flaw of character. Now, how much contempt for and misunderstanding is there of people who inject drugs amongst the general public, and why is it there? And I'm going to give you a quote from a doctor, and some of you have had this quotation before. It's from last year, and it was in the Wall Street Journal. This is from a doctor, the director of the Illinois program for hepatitis treatment. And he said, prescribing sofosbuvir, the new hepatitis C medicine, to someone using heroin would be a total waste. It would be a complete waste to give medicines to somebody who injects drugs. And I think this is an extraordinary proposition, when people who inject drugs are the largest, the population that carries the greatest burden of hepatitis C infection. Now, whilst we usually think of people who inject drugs as being ravaged by two twin epidemics, hepatitis C and HIV, there is in fact a third one. And this third epidemic is much more secret, but it's one that we've been talking about today. And it plays a crucial role in driving the other two, much more known infections. And this very hidden epidemic is that of mass incarceration, because people who inject drugs are amongst the very largest proportion of those you find in jails around the world. So I've given you the figure, 54 to 69% will at some point find themselves in jail. Often finding themselves trapped in a revolving door of ever longer spells behind bars, with each of which people who inject drugs find themselves ever more exiled from the body politic and with ever more tenuous links to broader society. Ernie Drucker, in a book that he wrote called, I forgot the name of the book, it studies public health infections in prisons, talked about a prison term leading to a lifetime of full or partial incapacitation. And he was writing about the United States, but I think it's a more widely applicable thought. And what he says is that a prison sentence transforms a life, a finite prison sentence, a finite sentence of incarceration, turns a life into a lifelong disabling condition. And it's perhaps truer of the United States than of other countries, but it's certainly worth thinking about. When you come out of prison, your life is irrevocably changed. Now, restrictions placed on ex-felons in the United States include restrictions on access to employment, and that's true outside of the United States. Many choices of employment are closed to you once you've been a felon. You are restricted in your access to housing, to public benefits, and to civic participation. And so added to the stigma of being a felon is that which adheres, as I've referred already, to people who inject drugs already. This is something that disables people's ability to function effectively in the outside world and cuts them off. In the United States, one of the most basic tenets of democracy, and we'd all agree on this, your country makes it necessary, is the right to vote. The right to vote is the most basic tenet of democracy. Yet 5.1 million Americans are denied the right to vote because of a felony conviction, felony disenfranchisement. Most Western democracies allow inmates to vote. In Australia, it is legally mandated, with a fine being subject if you fail to vote, and that includes prisoners. Whilst in the US, felony disenfranchisement is a matter of state law for all but 2 states. And the bulk of that burden falls upon the injecting community and upon the African American community. 2/3 of whose young men are denied the ability to vote. So this has enormous impacts upon people's ability to participate in civic life. Now, in addition to all of this, and very specifically for people who use and people who inject opiates, is that release from prison massively raises the chance of overdose. And we've seen a discussion earlier about the need for harm reduction education, yet not once was the need for naloxone discussed. More and more prisons around the world, we're seeing naloxone, which reverses opiate overdoses, being discussed and being provided upon release from prison, yet we do not see naloxone widely rolled out within prisons. This is, again, I find something that is extraordinary when a shot of naloxone costs barely 50 pence. I'm going to come back again to the prison needle exchanges. I want to talk a little bit about housing. I was in Sydney last week and was speaking to a friend of mine. There was an accord being drawn up between a local housing authority and a local police authority in an inner city district of Sydney, with a very large injecting population and a very large Aboriginal population, the two populations which coincide very neatly. And the MOU that is being sought is to give the police access to the criminal records of current tenants. And if convictions of drug offences are found, people will be evicted from their council housing. And this will be applied forward-looking for prospective tenants. So people with drugs convictions, and I'm talking about possession convictions, will be denied housing. The most basic level of Maslow's pyramid, the right to shelter, is being denied to people simply on the basis of having a drug conviction. We've seen people already being denied the right to vote. This is an extraordinary degree of malice, misunderstanding and loathing for people on the basis of, again, what drugs they choose to use. Why is this? Now, at the same time, entry into OST programs with their minutely pedantic rules, regulations, disciplining and infantilizing procedures fulfill at least 2 key functions. And I've been in them, I know what they do. They act to break down resistance. They break you very effectively. They make it hard for people who use drugs to function fully in society. It's very difficult to hold down a full-time job if you're in an OST program. Their opening hours are damn inconvenient. They leave you hanging around for a very long time. They're in inconvenient places. They embed stigma very, very deeply within our psyches, within people's internal roadmaps, such that the only language, the only discourse that is possible, that is tenable when talking to the staff of an OST program, principally to a doctor or a harm reduction worker, is that the ultimate goal is recovery, is one in which people who use drugs are framed as patients, to be cured, as broken, as traumatized people in need of mending, and as weak people who need supporting. And this again is, I find, something that is profoundly corrosive. You become a weak person. you become infantilized. And I'll illustrate this with a story that some of us heard last week, told by an Australian member of the injecting community, who was seeking takeaway methadone to go to the conference in Sydney on hepatitis C in people who inject drugs. And he wanted to go on holiday with his mother. And so he told this to his doctor, and his doctor said, well, I will need your flight tickets. And he said to his doctor, well, we're driving. And he said, well, in that case, I'm going to need your hotel reservations. And my friend said, well, we don't know where we're going to stay because we're going to be driving from place to place. And this is a man in his 30s. He'd been with this doctor for a very long time. And the doctor was beginning to despair because he was under instructions from his senior. And he said, well, in that case, can I have a note from your mum? Can I have a note from your mum? Dear doctor, this is your patient's mum. He wants to come on holiday. Could you please give him his methadone? It's extraordinary. So, prison needle and syringe, what has all this to do with prison needle and syringe programs? How much longer have I got? I've been way too long. Okay, I'll finally deal with the issue. Now, what is the narrative? You ask, what is the narrative? The narrative is really very simple. It's called human rights. It's called the Principle of Equivalence. What we are talking about here are universally recommended, universally advised interventions and programs that are unbelievably efficacious. You do not want people to contract a virus that may lead to liver cancer. You give them clean needles and syringes. How many times has a needle and syringe used in a prison needle and syringe program been used as a weapon? How many times in the world? Never. Not once. The assumption that people who inject drugs will use needle and syringes as weapons illustrates again the lack of understanding of why it is that we want clean needles and syringes. We want them to be sharp. We want to use them. If you hit someone with it, it will be blunt. It will not work. They have never been used as a weapon. Cutlery is very often used as a weapon. Cutlery is very often used as a weapon. Needles and syringes, never, not once. That argument is absolutely ridiculous. It collapses. I understand the feelings of prison guards, but we are talking about the health of people who are sent into prisons because their use of drugs is deemed to be inappropriate and criminal. I'm going to leave it there. People will not use their needles and syringes as weapons.